It's my pleasure to introduce Dr. Sarah Hamidi. Dr. Hamidi is a board-certified endocrinologist currently completing a 2-year oncologic endocrine fellowship at MD Anderson Cancer Center in Houston, Texas. Her main interests are advanced differentiated thyroid cancers and anaplastic thyroid cancer. Under the mentorship of Dr. Maria Cabanillas, she is participating in various research projects with the aim to improve treatment and outcomes of this rare yet very aggressive disease. Welcome, Dr. Hamidi.
Thank you so much for the introduction. Can you guys, test, can you guys hear me okay? Okay. Is it fine? Okay, perfect. So it's my pleasure and honor to be with you here today this afternoon to talk about emerging treatments and future trials for advanced differentiated thyroid cancer as well as anaplastic thyroid cancer. I have no conflicts of interest to disclose. So during the next hour, what we're going to do is discuss the limitations of the currently available treatments for advanced differentiated thyroid cancer and anaplastic thyroid cancer, which I will be referring to as DTC and ATC. And then we're going to review the novel emerging treatments and the ongoing clinical trials for these two diseases. So just a little bit of background, I'm sure most of you are aware of this, but most differentiated thyroid cancers are going to have an excellent prognosis after treatment with surgery plus or minus radioactive iodine, but there's still 5 to 10% of patients that are going to develop distant metastatic disease, so disease outside of the thyroid or the neck, and these distant metastases go most frequently to the lungs or the bones. And about half of patients with distant disease are going to be refractory to radioactive iodine, which is usually our our regular treatment for differentiated thyroid cancers. And these patients refractory to radioactive iodine represent less than 5% of all thyroid cancer patients. What do we mean by radioactive refractory? So what we mean by that is either that the disease does not take up radioactive iodine at all, so the first picture, or some of the lesions take up radioactive iodine, but others don't, which is the second picture. And then the lesions can take up radioactive iodine, but the disease still progresses, so the radioactive iodine didn't work. And this also counts as radioactive refractory disease. Even with distant metastases and even with radioiodine refractory disease, this does not mean that we need to start systemic therapy or chemotherapy right away because of the nature of thyroid cancer, which is in general indolent and slowly progressive. And so in many cases, we can just use targeted therapies or watch the disease as it slowly grows. And it's only when the disease is growing more rapidly or causing symptoms that we consider starting systemic therapy. Anaplastic thyroid cancer now is a bit of a different kind of disease. It's quite rare, but a deadly kind of thyroid cancer. It represents only 1 to 2% of all thyroid cancers, but it's responsible for up to 50% of thyroid cancer-related deaths. And up to very recently, this disease had very poor prognosis with a median survival of about 5 months. But thankfully, in the past decade or so, there has been significant improvement in the survival of patients afflicted with anaplastic thyroid cancer, especially since we found that some of these patients have a BRAF V600E mutation that we can target with specific treatments. And we're going to talk about that a bit more in a few minutes. So how does thyroid cancer happen? There are 2 major pathways that can be affected and that lead to the development of a thyroid cancer. So we have these 2 pathways, the MAP kinase pathway on the left and the PI3 kinase pathway on the right. And these pathways, what they do in a normal cell is that they are going to stimulate the growth and proliferation of cells. And anywhere in these 2 pathways, we can have mutations that are going to stimulate excessive tumor growth, excessive cell proliferation, and this leads to eventual formation of a tumor. And we have, over the past decade, seen the development of drugs that target different actors in these pathways. So for example, we have BRAF inhibitors, which are listed here, dabrafenib being the only one that's FDA approved for thyroid cancer. And so it comes and blocks the BRAF that is mutated and overly activated, and so blocks the excessive proliferation. We often combine the BRAF inhibitors with MEK inhibitors, such as trametinib, that also is going to block the MEK and block the excessive proliferation. We have mTOR inhibitors like everolimus or Afinitor, which we also sometimes use in thyroid cancer, but is not FDA approved. And then other than mutations in the pathways themselves, we can also have some of the receptors or the proteins that activate these pathways that can be mutated, such as RET or TRK fusions that we sometimes see rarely in thyroid cancer. And these can also be targeted by drugs that are FDA approved, like RET inhibitors or NTRK inhibitors. Now, what do we do if we don't have a mutation that can be targeted with specific therapies? Well, we usually use what we call antiandrogenic drugs, so drugs that target the vascularization of tumors, and that they're going to cut off the tumor's blood supply. Why do we use that? Well, because tumors depend on oxygen and nutrients that are brought to them by the blood to survive. So here on the left, you have a tumor, an example of a tumor who, when the tumor grows and becomes big enough, it's gonna need more oxygen. And so to get more oxygen, it's gonna secrete this protein or substance called VEGF that's gonna increase the blood supply and oxygen delivery to the tumor. So we're gonna have VEGF is gonna go on its receptor called the VEGF receptor, and it's gonna increase the amount of blood vessels feeding the tumor. And so the tumor is gonna be able to grow and survive. And so what we do with the antiandrogenic drugs is that we're going to block the VEGF receptor and so cut off this increase of blood vessels and the increased blood supply. There are a few drugs in this category that are available for thyroid cancers. The three listed here, lenvatinib, cabozantinib, and sorafenib, are the ones that are FDA approved for advanced thyroid cancer. So in summary, over the past decade, we've seen development of many drugs, and I know this is a heavy figure, it's just to show that we have multiple drugs available, but yet we're still far from having a perfect treatment for thyroid cancer. And these different treatments that we have multiple limitations. So first, none of them offer cure. Most of you know that when we start systemic therapy for thyroid cancer, it's a lifelong thing, so you need to stay on these drugs long-term, and none of them actually cure the thyroid cancer, they mostly control it. These drugs come with various side effects. Some are more toxic than others, but most of these drugs have some side effects of some sort. And then we've seen over time that eventually a lot of patients are going to develop resistance mechanisms to the drugs that we're using to treat their cancer. And so the tumor is going to escape the control with the drug and progress. And we also saw that some mutations still don't have some specific therapies that are targeting them. So the quest for a better treatment for thyroid cancer continues. Now, before we go any further, how are we going to assess the efficacy of a new treatment that's being studied or on trial? So we use a few things. We use the RECIST criteria. So what RECIST is kind of just language that we're using to make sure that everyone's talking the same thing when evaluating response to therapy. And basically what we do is we pick a few tumor spots, measure them before treatment, and then follow their response while we're using the therapy. And we see if these spots shrink, grow, or stay stable. If there's a reduction of 30% or more, we talk about a partial response. If all of the tumor spots disappear, then it's a complete response. And if there's a growth of 20% or more, then it's progressive disease. And if it's between the partial response and progressive disease, then it's stable disease. And in trials, we're often going to report what we call the overall response rate. So that means that it's complete plus partial responses put together, and they give us a percentage. And that's how we can compare treatments and their efficacy. We also look at the impact of a treatment on survival. So there's two outcomes. We look at overall survival and progression-free survival. So overall survival is basically from the time of treatment start to when the patient passes away or when the last follow-up. So how long has the patient been alive since getting this treatment? And then progression-free survival is how long has the treatment been able to keep the tumor under control. So it's from the beginning of treatment to the first evidence of the disease progressing or the last follow-up with the patient. And the survival outcomes are often going to be reported on curves like this. So we have on the x-axis time, and then on the y-axis, we have either survival probability or progression-free probability. And we also often report medians, so meaning the time needed for 50% of patients either to pass away or progress on disease. So now let's talk about the different treatments or strategies that are being studied to kind of overcome the limitations of the currently available treatments. So first we have redifferentiation therapy. And what does this mean? It means that we're trying to resensitize the tumor that was previously radioactive iodine refractory. We're trying to resensitize it to be able to uptake and respond to radioactive iodine. So what's the concept behind that? So the idea is that the MAP kinase pathway, which we talked about and said is involved in the tumorigenesis of thyroid cancer. So what it does, it stimulates different genes to be made, and some of these genes are going to inhibit the ability of iodine to get into the cells. But when there's no mutation and the pathway is functioning normally, this inhibition is minimal and the iodine is still able to get into the cells. But when we have a mutation that's overactivating the MAP kinase pathway, like on the figure on the right, the pathway is overactive, so these genes are present in excess and the iodine cannot get into the cells anymore. And so by blocking different spots, different levels in the MAP kinase pathway that are mutated with the different drugs that we have, we're able to stop this excessive activation and allow the iodine to get into the cells again. And so there are different trials, different case studies, we can say, not formal trials, that have looked at this approach and to see if it's working or how efficacious it is. So for example, this is one of the first trials using a MEK inhibitor called selumetinib. And we can see that at baseline, very few of the lung metastases were lighting up, so taking up radioactive iodine. And after therapy, significantly more uptake, as you can see on the right. And this is another example of some patients we treated at MD Anderson. And again, on the left, you can see their diagnostic iodine scans before treatment. So anything that's black, that's something that's taking up radioactive iodine and lighting up. And so on the left figures, you see very little uptake, and then on the right side, we see a significantly more uptake. For example, this patient here, so the third patient, significant uptake in the lungs after treatment, whereas before, very little uptake or none in the lungs. So how does redifferentiation work? So what we do is first we have to choose the right candidate. It doesn't work for everyone. It's an approach that we use for differentiated thyroid cancer, so PDTC, papillary, follicular, and poorly differentiated thyroid cancers. It's not something that we use in anaplastic. The disease has to be progressive and radioiodine refractory. And then the patient has to have received less than 500 millicuries over the lifetime so that we don't give them too much radioactive iodine. We think it works for smaller lesions. So usually we like lesions to be less than 3 centimeters. And then if they have any disease in the brain, it has to be treated and well controlled. And then we start the systemic therapy and we give it for about 1 to 3 months. And then we do a diagnostic whole body scan. So we give a small dose of radioactive iodine to see if the uptake has been restored. And then we treat the patient with radioactive iodine. And we do another whole body scan about 3 to 5 days later to see the effect of our treatment. So if uptake has been restored. And then that was it. And we stop the systemic therapy about 3 to 5 days after giving the radioactive iodine. And then we watch the patient off of systemic therapy. And the idea is to try and give as much time off of chemo as we can to the patient. And so avoid all the toxicities that come with these treatments. And this is an example of a patient, again, that was treated with this approach. And then about 2 to 3 months later, we restage to see if our approach worked or not. And eventually, when the disease progresses again, because this approach does not offer cure either, we resume the systemic therapy. So the good thing about redifferentiation is that when it works, it leads to disease stability or even shrinkage in some patients. We're able to give time off of systemic therapy. And in some trials, they showed about 15 months of median time off of chemo, and it has minimal toxicity. But there's a lot left to understand about this treatment strategy. We don't really know who are the best candidates. We try it in a lot of patients, but some of them respond and some don't. So we still have to understand who is the best candidate for this, what are the optimal drugs to use, and also how long we need to give the chemo before giving the radioactive iodine. There's one ongoing trial looking at redifferentiation and DTCs with red fusions using the drug selpercatinib, and it's currently enrolling at MGH. So now switching gear a little bit, we're going to talk about new targeted therapies or new strategies using the targeted therapies that we have. So we talked about the BRAF mutation. So BRAF V600E is the most frequent mutation in differentiated thyroid cancer, and it's also present in about 40% of ATCs. And currently what we use for patients who have a BRAF V600E mutation is a combination of a BRAF inhibitor and a MEK inhibitor, so the BRAFenib and trametinib that you can see on the figure on the right, blocking the MAP kinase pathway like we saw already. However, cancer is unfortunately smart and has when we treat with BRAF/MEK inhibitors, it finds ways to overcome this inhibition and it finds way to continue growing despite these drugs that we're giving. And there's different ways that the cancer can do that. Either the receptor at the top of the cell, which is stimulating the MAP kinase pathway, is overactivated, or the tumor can acquire a new mutation. So on top of the BRAF mutation that's already there, we can have new mutations that emerge and that are able to bypass the BRAF/MEK inhibition. And we can also have just activation of the other pathway, the PI3 kinase pathway, that can become overactive and then lead to tumor growth. So there are different strategies that are being studied to overcome all of these resistance mechanisms. One of them are next generation BRAF inhibitors. So they have been developed for patients that failed the current available BRAF inhibitors. They have more potent BRAF inhibition. They penetrate the brain, so they're efficacious for brain metastases as well. And they seem to have some less toxicity, especially less skin tumors that we can sometimes see with the BRAF/MEK inhibition. And so there are 2 trials currently enrolling looking at next generation BRAF inhibitors. And so this is going to be something to be on the lookout for. The other way that we're trying to overcome the resistance mechanisms is by combining the dabrafenib or the BRAF/MEK inhibitors with other kinds of drugs. So for example, there's this new drug, which is an SGK1 inhibitor. So what is SGK1? So again, when we give the dabrafenib, we're blocking here the BRAF and MEK, but other things can become activated and still stimulate the pathways and tumor growth despite these drugs that we're giving. And so SGK1 was found to be one of these things that is overactive and is able to stimulate the MAP kinase pathway despite the dabrafenib. And so this new drug, the Thrive 1257, inhibits the SGK1. And so it could be able to overcome this resistance mechanism. And actually, they studied it in mice with ATC. And so in the light blue, you can see DT alone, so the dabrafenib alone. And then when they added the study drug to it, the Thrive, we can see that the tumors shrink significantly. Another approach also is targeting the HER2 receptor. So another way as well that the tumors have found to overcome BRAF/MEK inhibition is by overactivating this receptor called HER2. And this is a receptor that's involved in breast cancer. So there are drugs already that inhibit this. And so we are looking to see if using drugs like this one called lapatinib, which is a HER2 inhibitor, would work in patients who have failed BRAF/MEK inhibitors. Now, we talked about BRAF, but switching gear a little bit, RAS is also a relatively frequent mutation in thyroid cancers. It's actually the second most frequent one in DTC, and RAS being the most frequent of the RAS mutations that we see. And it's also a relatively frequent mutation in ATC as well. So BRAF is the most frequent, but then the second most frequent is RAS. And we know that patients who have RAS mutated ATCs have a less good prognosis compared to patients with a BRAF mutation. So blue is BRAF on the survival curve, and then the green is the RAS mutated, and we see that their overall survival is inferior to patients with a BRAF mutation. And unfortunately, currently, we have no specific treatment targeting the RAS mutation. So in these patients, usually what we do is use the antiandrogenic drugs like we talked about. At some point, we thought that the BRAF inhibitors would work for RAS mutated because RAS is above BRAF. So if we're blocking below, we thought that it would work. But it turns out that RAF signals as what we call a dimer. So it needs 2 different proteins to send the signal. And if we block just the BRAF, then this other, the partner, which is CRAF, is going to be overactivated. And so the pathway is still going to be able to signal, and the tumor is still going to be able to grow. So one of the drugs that's being developed to try to overcome this is what we're calling pan-RAF inhibitors or RAF dimer inhibitors. And what they do is that they're going to block both the BRAF and the CRAF and block completely the signaling of the pathway. And these are very hopeful drugs, and we have a lot of expectations, and we're hoping this works because it's going to be a good treatment strategy for patients with the RAS mutation as their primary driver mutation, but also all of those that have acquired a new RAS mutation as a resistance to their current treatment. And it's being studied for both ATCs and DTCs. And there are multiple different drugs within this category that are being currently studied in phase 1 trials, and you can see the list here. And then the other type of drug that's also being studied kind of with the same idea for RAS mutated tumors is our ERK inhibitors. So they're going to inhibit more downwards in the pathway. And there are 2 trials that are currently ongoing with these drugs. So now we talked a lot about chemo, but I'm going to switch gears a little bit and talk about other kinds of approaches that we're looking at or studying to improve outcomes in advanced thyroid cancers. And one of those is the neoadjuvant approach. So what does neoadjuvant mean? What it means is that we're going to use systemic therapy to shrink a tumor before going for surgery to make the surgery either feasible because the tumor was not resectable in the first place, or to make surgery less morbid. So let's say surgery would need a laryngectomy, patient would end up with a tracheostomy. We try to make the tumor smaller so that the surgery is less morbid and the patient has better outcomes afterwards. And so the neoadjuvant approach is being looked at in DTC. It's not yet routinely used in differentiated thyroid cancer, but there are 2 trials that are ongoing looking at it. There's a trial with lenvatinib, so an antiandrogenic drug for locally advanced DTCs. And there's also a trial with selpercatinib for tumors with a RET fusion. And this, I just wanted to show an example of how good this approach can be. So this is an example of a patient with an advanced papillary thyroid cancer, which was treated with lenvatinib. Before lenvatinib, we can see the tumor here, which was encasing the blood vessels. It would have been a very difficult surgery. And after 7 weeks of lenvatinib only, we can see that the tumor shrunk significantly. The neoadjuvant approach is way better established in anaplastic thyroid cancer, and we have been using it at MD Anderson for a few years now. And we have shown that with this approach, by shrinking the tumors, so anaplastic thyroid cancer is often, very locally advanced, big tumors that can be encasing the blood vessels, the airway, the esophagus. And so by using the brafnib trametinib plus pembrolizumab for tumors with a BRAF mutation, we are able to significantly shrink these tumors and make the surgery less morbid. We're also able to make tumors that are initially unresectable resectable. And we also showed that it improves these patients' survival. And actually, in a recent study that we're soon going to publish, we showed that the median survival in these patients is over 5 years. And we remember that we said that a few years ago, median survival was about 5 to 6 months. So significant improvement in the prognosis of patients with BRAF mutated ATC. And this is just an example to see the impressive responses we see with neoadjuvant, the brafnib trametinib pembrolizumab in anaplastic thyroid cancer. So these are PET scan images. If you're not used to seeing them, the black is the tumor. And so we see that there's significant shrinkage of these tumors, allowing complete resection and the decreased need for tracheostomy in these patients. And so for now, this is just our experience at MD Anderson, but there's a formal trial that's currently ongoing that's enrolling at multiple centers in the US to look at this more formally. I'm going to talk a little bit about immunotherapy. So I mentioned pembrolizumab in the previous slide. That's a kind of immunotherapy. And so immunotherapy is being increasingly studied in advanced thyroid cancers. So what is immunotherapy? So first, checkpoint inhibitors, which are a kind of immunotherapy that we're studying. So if we go back a little bit, before talking about the checkpoint inhibitors, how does the immune system normally work when there's a cancer infection or anything threatening our body? We have these cells that are going to recognize the threat, and then they're going to show it to our T cells, which are kind of the soldiers that are going to attack the cancer or the infection. The T cells are going to be activated, and then they're going to go kill the infection or the cancer. However, the body is made in a way so we don't want this immune response to be too excessive and to go crazy. So we want to make sure that we're controlling these T cells for them to target the tumor only and not the rest of the body. So we have what we call immune checkpoints, which are checkpoints to control the immune response. And there are 2 main kinds, so the PD-1, PD-L1, or CTLA-4. And both of them are just going to control either the activation or the activity of the T cells, so that they don't go too crazy. And what we've been able to do is to develop either PD-1, PD-L1, or CTLA-4 inhibitors to kind of block this inhibition of the immune response and allow the immune system to be activated again. And actually, cancers use these immune checkpoints to escape the immune response. So Here you have the T cell, which has a PD-1 receptor on it, and it's supposed to recognize, and it's supposed to go and kill the cancer. But we said PD-L1 is a checkpoint inhibitor. So the tumors can have PD-L1 on them, and so they're going to use this to kind of shut down the response of the T cells. But when we use a PD-1 or PD-L1 inhibitor, either with the PD-1, we're protecting the PD-1 of the T cell, or with the PD-L1 inhibitor, we're impairing the PD-L1 of the tumor cells. And both of these drugs are just going to reactivate the T cells and make them available to attack the cancer again. And same concept with the CTLA-4 inhibitors. CTLA-4 is also used by the tumors to shut down the T cells or make them less active. And by inhibiting this, so protecting it, the cancer cannot use it anymore, and the T cells are active again to attack the cancer. So basically, this is a little bit of a, I wanted to try and make it as simple as possible, but the immune checkpoint inhibitors, what they're going to do is just they're going to reactivate our T cell response against the cancer cells. And so we have PD-1, PD-L1 inhibitors and CTLA-4 inhibitors. In differentiated thyroid cancers, we've learned that these have little efficacy when we use them alone. And what we're trying to look at now is combination of these immune checkpoint inhibitors with some kinase inhibitors, so like lenvatinib or cabozantinib, and there are a few trials that are ongoing. Here you can see the preliminary results of these trials, and we can see that the responses are quite variable, but we're going to wait and see for the final results to see what the efficacy of this is. Now, in anaplastic thyroid cancer, immunotherapy is better established, and we have seen better results with this. And actually, if we use kinase inhibitors alone in anaplastic thyroid cancer, we saw that the responses are quite short-lived. So on the left, you see the brafnib trametinib for BRAF mutated ATCs. When we use these two drugs alone, the median duration before progression is only 6.7 months. And for lenvatinib, which is used for tumors that don't have a BRAF mutation, the median duration before progression is only 2.6 months. But when we add immunotherapy, the duration of response is prolonged, both for dabrafenib, trametinib, and lenvatinib, and we also saw improvement in survival for these patients. On the left, for dabrafenib, trametinib, we see that the overall survival goes from 9 to 17 months, and with lenvatinib pembrolizumab, which is an immune checkpoint inhibitor, the median overall survival is 11 months. So immunotherapy added to the kinase inhibitors in anaplastic thyroid cancer really improves outcomes and survival. The other way we're using immunotherapy in anaplastic thyroid cancer is what we call in the adjuvant setting. So in patients that have tumors only in the neck, no distant disease, so stage 4B anaplastic thyroid cancer, historically what we used to do is only do surgery followed by chemotherapy and radiation, and then we watch these patients. However, with this approach, recurrence rates are quite high, and you can see the curve on the right with the red arrow. Those are the 4B patients, and the median time to recurrence is about 6.2 months if we use this approach alone. And what we've been trying to see is if we add immunotherapy after surgery, chemo, radiation, we think that immunotherapy is going to prolong the duration of response and is going to avoid these recurrences, or at least make them come later on. And so there's a trial ongoing right now looking at pembrolizumab in the adjuvant setting for patients with stage 4B ATC that's currently enrolling. The last thing I wanted to talk about is CAR-T, which is also a kind of immunotherapy. So what is CAR-T? So it stands for chimeric antigen receptor T cell therapy, which uses a genetically engineered lymphocytes that are reprogrammed to recognize and eliminate tumor cells expressing specific antigens. These kinds of treatments have shown impressive results in hematological malignancies, so leukemia and lymphoma, and now we're looking at it for more solid tumors like thyroid cancer. So I found this other cartoon that I found really cute and explains well the CAR-Ts. So we talked about T cells already. The T cells are what are supposed to attack the cancer or any abnormal cell that it's in our body. But when we have the cancer protects itself and makes the T cells not efficient anymore to attack them. And so when we re-engineer the T cells with the CAR-T, we make them able to attack the cancer again, recognize it and attack it. And so there's a trial that's currently ongoing for anaplastic thyroid cancer and poorly differentiated thyroid cancer that's looking at a CAR-T that targets this molecule called the ICAM1. And so to be eligible for this, this trial, the tumor has to express the ICAM1. And so it's to look at the CAR-T is going to target the specific protein that's expressed by the cancer. And we're going to see if it helps these patients that have failed other lines of therapy. So in conclusion, I think we can say that major progress has been made in the treatment of advanced differentiated thyroid cancers and anaplastic thyroid cancer in the past decade. However, nothing is perfect yet, and the currently available treatments still have some limitations. They have toxicities. We saw that most of them have limited duration of efficacy because the tumors acquire resistance, and none of the treatments that we currently have offer cure. However, there are multiple strategies that are being studied that we reviewed together today to overcome these limitations. And so I think that in conclusion, we can see that the future is bright for advanced thyroid cancers. Thank you for your attention.
The drug you talked about that blocks the blood supply, how does that affect the rest of your body in terms of blood supply?
Yeah, so these drugs, the antiandrogenic like lenvatinib and such, are kind of our most toxic drugs for advanced thyroid cancer, and that's why they come with a lot of side effects because they block these blood vessels. So that's why they have risk of high blood pressure, or they can also cause bleeding. And so this is, this is the effect of acting on blood supplies. So they do affect other organs and other tissues, and that's why they have all of these side effects.
Let's
Another question for those resistant to RAI and your fix for that. You went on to say that, or at least in your graph, that you restage at a certain point. In an earlier presentation, I heard that staging only happens at initial diagnosis in thyroid cancer. So I was curious about the difference there. Because I'm assuming someone who's resistant to RAI, you already know they've been through some type of treatment. So they would have been staged already at an earlier point.
Yeah, so initially we staged the disease to determine what kind of stage, 1, 2, 3, 4. And then throughout treatment, every time we reassess the response by doing scans, see how the disease is responding to whatever treatment we're using, we call that a restaging. But we don't change the initial stage. So let's say your tumor is stage 4 or 3 initially, that's going to be your stage forever. But every time we reassess the disease, we also call a restaging.
Hi, with the SGK1, that I forgot which drug you combined it with to help it be more effective.
It's added to the trametinib.
Right.
Yes.
So would that also work with Lenvima?
So this is just starting to come out, this drug, and it's only been studied in mice right now. So they're studying it with addition to the trametinib. But this, we never know what the future holds and whatever we see with this drug. Yeah. Oh, so the first question is, I know this will sound crazy at this point, but is there any news that might actually point to a cure for ATC? We would all love that, and, but I think we've made a lot of progress already. And with our neoadjuvant approach and then the trametinib pembrolizumab, we're seeing very long-lasting responses. So although it's not a cure in the sense that you are able to stop any treatment, I think we're getting closer than we were at least. So the next question was, can you please address if there are any treatments targeted towards the TP53 mutation? There are no drugs that we use in thyroid cancer targeting this mutation directly. And this is not, the TP53 mutation is not a driver mutation for the cancer. So it's not what's causing the thyroid cancer per se. And so I think this is why we're not looking to target it specifically. It's a marker that we look at that make us think that the tumor might be more aggressive than others, but I don't think that there's necessarily a point in targeting this mutation directly for therapeutic purposes. So the third question is, are there efforts being made to use these or other strategies or therapies in an effort to retain some functional thyroid? So in these advanced thyroid cancers, usually we need to do complete surgeries and take out the whole thyroid. So none of these treatments is looking to keep some of the thyroid in, no, not that I know of at least. Okay, so next one is, So what treatment is there for lucky people with ATC that are BRAF, NRAS, KRAS, HRAS, and RET negative? So the treatment we usually use at this time for patients that don't have a BRAF mutation, even the RAS mutated at this point, we're using lenvatinib, so an antiandrogenic with immunotherapy. So lenvatinib with pembrolizumab. This is the approach we're using right now. And we're seeing encouraging results with this approach, but hopefully in the future, we'll find other treatments.
Hi there. In one of the earlier sessions, and I hate to make you quote an earlier doctor, but they brought up the astronomical cost of the CAR T cell. I think he said it was between $500,000 to $1 million. And I'm curious, are you finding insurance companies budging on that, or how generous are they, even if you do happen to express that one marker that you said you were looking for? Are they paying for it?
Since it's a trial, I have not heard of problems with coverage because it's in a trial setting for this particular, for the anaplastic thyroid cancer and poorly differentiated. So it's in a clinical trial, so it's being paid for.
Oh,
I think what it is that before the patients go on the clinical trial for CAR-Ts, the clinical trial people contact the insurance to see if this patient is covered and the cost will be discussed, and if the insurance allows, then this patient goes on. There are patients going on it, but right now it's not FDA approved treatment, so we're not ordering it or using that treatment outside.
yeah, I can't see insurance companies jumping through hoops to pay for that.
Ryan wants to clarify because he's saying does all of this apply to BRAF V600 in PTC as well? Yeah, so PTC, I didn't clarify initially, but differentiated thyroid cancer includes papillary, follicular, and poorly differentiated. So everything I said applies for the papillaries as well, of course. Is there a combined TKI therapy and immunotherapy that has produced favorable results with HER2 cell? Unfortunately, our big beast right now, it used to be RAS mutated cancers. Now that we have some hope for the RAS mutated, we're gonna hopefully focus more on HER2 cell, but that's our big beast right now for which we don't have good treatment options, unfortunately. What percentage of radioactive iodine, I guess refractory thyroid cancer patients end up progressing? I have RET mutation and have been stable lung mets for 12 years. Do most patients eventually progress? So, I mean, not all patients have to progress. Some patients stay with low volume, so small disease outside of the thyroid in the lungs or in the bones that can remain stable for many, many years with only TSH suppression like yourself. So not everyone has to progress. And I think that the fact that you've been stable for 12 years is a good sign that most probably progression might not happen. But we still need to follow up and keep an eye on things because we never know if things might progress at some point, but not everyone has to necessarily progress.
Thank you. Forgive me if this was on one of the slides. There was a lot of information to take in. Do you see the possibility of the CAR T working for the BRAF, the patients who are currently on the BRAF MEK combination, if and when it ever were to stop working and you start to see progression?
Yeah, so if the tumor expresses the ICAM1, then we can use the CAR T.
After that treatment?
Yes.
Okay.
Yes.
Okay. Would autopsies of people who have undergone treatments help going forward, people in the future,
I don't know
to
if
advance the cause?
Yeah, I don't know for autopsies, but what we're trying to look at as patients who failed some treatments and developed resistance, we're trying to study these tumors to see what they've acquired, to make them resistant, and also patients that for whom the treatment just doesn't work, because some patients, just don't respond to some of the drugs we have. Then we're trying to look at these tumors to understand why they're not working. Not sure if autopsies would bring anything more because the treatment, is over and all that. So I think it's patients that are undergoing treatment but failed this treatment, trying to understand how they failed it will help us progress definitely.
So asking if you're in a teaching institution like MD Anderson or Sloan, and your current TKI stops working, would you be asking your doctor, could you biopsy and
Definitely. So that's
find out why?
Of course, yeah, we do that on a regular basis. So when the tumor fails a treatment we're currently using, we want to understand why. So we either do a biopsy if there's something that we can directly biopsy, a lesion that we can get, or if there's nothing that we can directly biopsy, we can also use liquid biopsy. So this is a blood test that's going to look at cancer cells that are in the blood and analyze them for mutations. And so this way we can see what are the new mutations compared to the tumor initially before the treatment and try and see why it progressed. And sometimes the new mutations that appear, we can target with specific drugs. So let's say you have a BRAF, you get a RAS, we can use a treatment for that.
I'm not that familiar with liquid biopsies. Does insurance pay for that?
I think so, yeah.
Yeah. Okay. And so I guess if your metastases that are no longer responding are in a pretty inaccessible or dangerous to the patient place, the next question would be asking the doctor, could we do a liquid biopsy
Yes.
and see if find out why?
Yes.
Okay, thank you.
Hi, I was just wondering, at what point do you make a decision to put a patient on TKIs? Like, is it the location is obstructing other parts of the body or size, or what is that decision factor?
Yeah, great question. So there's different situations. So I mentioned most thyroid cancers are going to be indolent, grow slowly, but at some point, if the disease starts growing faster at a pace that's concerning, that's going to be a reason for us to consider systemic therapy. If the disease is in multiple spots, and let's say just one lung spot is growing faster than the others and the others are stable, then we're often going to use targeted therapies to that. So either radiation or try to control just that one spot. But if multiple spots are growing at a more concerning pace, so let's say lung is growing and then bone spots are growing, then we're going to want to target all of those at the same time. And so that's when we think about systemic therapy. But also if the tumors for some reason are causing symptoms and we can't treat that locally, that's another reason why we can start systemic therapy. Or if the tumors are in localizations that can be threatening for what's around them, and again, we can't use radiation or stuff like that, then we think about chemo. So do you ever see different mutations in testing through blood versus biopsy? So that's an excellent question. Yes, we do. So I mentioned the liquid biopsy, basically what it does, it picks up for any cancer cells that are being shedded by the tumor and that are in the blood. But depending on how much cancer there is, it might not shed as much cells in the blood. So sometimes we can miss some mutations in the liquid biopsy. So the liquid biopsy is good when it's positive and it's showing us a mutation, but if it's showing no mutation, that this does not mean the tumor has no mutation. It just means that we did not pick up enough cells to look at the mutations. So the best thing to find resistant mutations is always to get tissue, but when we can't get tissue, then liquid biopsy can be a good alternative.
Could you repeat?
Oh yeah, so because anaplastic thyroid cancer and poorly differentiated thyroid cancers grow faster, so they're shedding more tumor cells in the blood, liquid biopsy is better for these kinds of cancer versus papillaries where they're more slowly growing. Often there isn't much tumor cells in the blood, and so liquid biopsy is less efficacious for these tumors. So the next question is, does an mTOR drug such as everolimus have efficacy as a treatment? So yeah, in some cases we do see efficacy with mTOR with the mTOR inhibitors, especially when there are mutations in the PI3 kinase pathway, because that's where the mTOR is working. So yeah, we do use it sometimes in clinic, especially when the first line treatments, so the FDA approved one, have failed, and we know that there's a mutation in the PI3 kinase pathway, we use this drug. Okay, then is there any link between ATM gene mutation and thyroid cancer? ATM, as I know of, is not a driver mutation for thyroid cancer. Sometimes we see ATM mutations in thyroid cancer that have a lot of different kinds of mutations. So it can be seen in like anaplastic thyroid cancer, but it's not a driver or a causal mutation for the thyroid cancer. So someone said you haven't mentioned the use of encorafenib and binimetinib. It was mentioned on my slides as the BRAF/MEK inhibitors, but it's not FDA approved. So this is why I didn't say the names of the drugs, but these are another combination of BRAF/MEK inhibitor that is approved for melanoma that we sometimes use in thyroid cancer when the patient does not tolerate the dabrafenib trametinib, which is the combination that's FDA approved. there another one in the chat?
I don't, is it?
Are the liquid biopsies going to replace biopsying the tumor? Would be easier than having to undergo biopsy. Liquid biopsy sensitive and specific as biopsying the tumor itself. So I think I answered this question already, but it doesn't replace biopsying the tumor because it's possibly less sensitive, especially for tumors that don't grow as quickly and don't shed as much. So I don't think it can replace, but it's a good alternative when we can't biopsy. And also it has a rapid turnaround time. We get the results pretty quickly. So sometimes it's a good preliminary analysis while we're waiting for the more extensive biopsy results.
That's all we have on the online. Is there any more?
Can I ask a question that's not treatment related,
Yeah, of
just
course.
cancer?
Yeah.
So, you know, in breast cancer, we have mammograms, and prostate cancer, we have PSA. Do we have anything for thyroid cancer for screening? In particular, should the children of thyroid cancer patients be screened, and if so, how?
So we don't really screen for thyroid cancer because of, in general, you know, it's a more indolent kind of cancer and all that. So, and it's a very frequent cancer in the population as well. And thyroid nodules in a lot of patients are never going to cause any harm. Or so if we do screen, then we're going to end up putting a lot of patients through biopsies and unnecessary surgeries possibly. So it's not beneficial to screen for thyroid cancer. And thyroid cancer is rarely genetic, so hereditary. So we don't screen kids of patients that have thyroid cancer unless we have some specific mutations, or if we see that it's clearly running in the family. So there are multiple relatives that have thyroid cancer. So 3 relatives of the patient, 3 first degree relative of the patient also have thyroid cancer. So that makes 4 people in the family. Then we think about screening, but otherwise we don't. No, ATC is anaplastic thyroid cancer. Yes. So we have differentiated thyroid cancer, which is DTC. Yeah, so that contains papillary thyroid cancer, follicular thyroid cancer, and poorly differentiated thyroid cancer. And then ATC is a different histology kind of thyroid cancer. Yeah, of course. So the question is, for poorly differentiated metastatic oncocytic cancer, how would you treat? Again, it depends on the mutation. Usually with oncocytic thyroid cancer or Hürthle cell, we don't have any mutations that we can target. And so often we use multi-kinase inhibitors in these tumors, and sometimes like lenvatinib, and we can combine that with immunotherapy if it's a poorly differentiated or more anaplastic kind of tumor. And then in your opinion, do thyroid issues run in families? So again, as I said, thyroid cancer is relatively frequent, especially in older women. And so if you have 1 or 2 relatives that also have thyroid cancer, it's most probably not something that's genetic, but there are rare syndromes that cause thyroid cancer. So with specific mutations, it can run in families, but in general, it's not hereditary.
If we don't have any more questions, we can thank Dr. Hamidi and really appreciate all that she's done for us.